know how good it is if you invite me back. Yes. Okay, so this lecture, I was given a 30-minute slot. So we only have, I lied, it wasn't 46 slides. It's only a delightful 48 slides, but we're going to go right through it. And usually I had case studies on it, but I had to pare it down a little bit. That's okay. We will get through it. How many of you guys rotated at Kings County Stroke? This is wonderful. This makes me so happy. How many of you rotated with me? Okay, everyone here is traumatized. Great. So, as you know, I am delighted to be here and thank you for inviting me, and we will speed forward. So, as you know, we're a trauma center that Dr. Feinberg talks in depth about traumatic brain injury. But also, I'm here to talk about the other side of bleeds, which is the intracerebral hemorrhage bleed. And we're a thrombectomy capable stroke center. Did you know that we're high performing in stroke by US News? You didn't know that. We're actually third year in a row. So very good. Shout out. Okay, good. All right. Anyway, let's move on. So these are my disclosures. We are participating in a couple clinical trials involving intracerebral hemorrhages. So I just want to let you know that we do see a lot. Now, Dr. Sinnott and I did collaborate in the ATAC-2 trial, which we will briefly talk about. And we actually will talk about our contribution to the ATAC-2 trial as well. And he could give you all the deets. Do people still say D? Oh, spill the tea. Yeah, he'll spill the tea on like what really happened, but I'll make it really like nice and rose-colored language. Okay. So we're here to talk about the 2022 guidelines that came out last year. You probably heard about this lecture, but I did add some more updates. The reason why it's important is to keep you, it's good for repetition. And also that intracerebral hemorrhages are only about 10 to 15% of all strokes. So you won't see it as often as ischemic stroke. You guys have a lot of education on ischemic stroke, but I'm here to talk to you about intracerebral hemorrhage stroke. But in the end, I also want to talk about how to take care of post-alteplase or post-thrombolysis related hemorrhages, which is extremely rare, but you need to learn how to take care of it. So intracerebral hemorrhages is about 15% of all stroke cases. It's associated with very high mortality rate. So if you had 30 cc's of blood in the brain versus 30 cc's of ischemic tissue, the person who's most likely to survive is the ischemic tissue versus the 30 cc of blood in the brain. And it's a very high mortality rate, about 1/3 may die, and that the most common causes actually that could be reversed is oral anticoagulation, which was brushed upon with Dr. Beta. And we do know that within 4 hours, a large percentage of these patients actually expand. So it's important to identify if the patient is on anticoagulation and also for reversal. The risk factors include, there are 2 independent risk factors that are associated with intracerebral hemorrhages. One is hypertension, one is cigarette smoking. And so it's important to engage the primary care team, the primary care doctors to really decrease that risk factor. Because but by the time they come to you, their blood pressure is over 220 to 230. So what I actually found very interesting is that when I go across the country and I look at intracerebral hemorrhage initial blood pressures, their blood pressures are not as high as our blood pressure, which I find very interesting. We see 220, 240 on a normal basis. But when I say that to other providers, they say, is there
Yeah.
You don't want to get switched?
I held it in though.
the PC term is I hear
It smells so good. Yeah, it makes it right even longer.
On the way there.
I went to a store.
Okay, great. All right. And the average age is between 40 and 60. Let's just move on. So I always use this slide. Dr. Hassel is my muse when I thought of this slide. And this is that, tell me what you want in a slide and I will remember the slide. So, intracerebral hemorrhage is based on approach of location of hemorrhage. And based on the location, if it's lobar, which is outside the periphery or cortical region, versus intraparenchymal, which is deep, what is the main cause of these types of hemorrhages and how are you going to investigate them? So for lobar, which is on the sides or in the corners of the brain, usually it's metastatic tumor. If you're dealing with the adult population, these are the 5 most common metastatic tumors that cause intracerebral hemorrhage. Amyloid angiopathy, convergent ischemic stroke, cerebral venous thrombosis, if you have a young woman or you have someone who is on exogenous hormones, as well as drugs, as well. And then you have intraparenchymal hemorrhage, it's most likely hypertension, but also traumas involved, malformation. What we do is, how does a primary hypertensive hemorrhage usually occur? It's the same as a stroke. Some people, I love it when I go down to the ED and I have an ED attending. It's usually Dr. Silver tells me, I think it's a bleed law. He doesn't call me Susan, he just calls me law. I think it's a bleed law. And I said, why? He says, because the diastolic blood pressure is high. And he's actually right. We find that if the diastolic blood pressure is greater than 110, and if they have nausea and vomiting associated with it, then we are leaning more towards hemorrhage. But the only way you can truly tell is by doing a CAT scan. The most damage is usually caused because of mass spec. Blood is not supposed to be there. So it's actually compressing the nerves and the neurons that need to be there. And 30% of the hematoma expansion occurs in the first 4 hours. And so usually associated with very high blood pressure. Everyone remembers this slide, but this is a very outdated ENLS, emergency neurological life support slide. And it's very outdated because these are the 3 areas that need to be updated regarding this, which is the diagnostic imaging that is performed. We no longer do just CAT scans for select cases, as well as blood pressure control and consideration of surgery, which Dr. Feinberg brushed upon. So I do want to tell you what's going on with Kings County. East of us, I used to have around 5 to 6 stroke centers before the pandemic. After the pandemic, around 3 stroke centers closed. And because of that, they've all been shunted to One Brooklyn Health and Brookdale Hospital. But then ultimately, we also got some overflow from that. So we actually shot up well over 100 cases in the past year. Just want to let you know. So normally we are used to our volume of 400. So we're seeing more strokes, and that includes more intracerebral hemorrhages. This is a breakdown of stroke cases based on diagnosis. And if you look at the dark blue, which is at the bottom, it's still the same here, but overall, we're seeing more ischemic stroke patients. And that's really important to realize that we are getting busier, and that means that you have to be on high alert and you have to be more familiar with your how to take care of your stroke patients in general. So when it comes to a patient arriving and you have diagnosed them with intracerebral hemorrhage, during your first hour, you should always evaluate for coagulation panel, as well as if there's surgical intervention and airway. I'm not going to tell a room full of ED doctors how to do airway management. I am the last person you should talk about airway. Usually, I always give them the story of how I was with Dr. Salloway and I said, the O2 sat is low. Do you think air needs to go into body more? That's what I basically told Dr. Salloway once. And he said, oh, you mean air needs to go into mouth hole? Yes, thank you. And then he went in and intubated the patient. That's basically what happened. So I'm not going to talk to you about airway ventilation. I'm going to talk to you about blood pressure, because I'm obsessed with blood pressure. If anyone has ever seen me in a stroke code, I am obsessed with blood pressure. And we will talk about blood pressure. So I always like talking about blood pressure. So these are the old guidelines there in 2015. It says that you should lower the blood pressure to 150, and that's it. and maybe lower it to 140 if you can. And this is based on the 2015 guidelines, which is well over 8 years old. And there are new guidelines since last year. But let me tell you the story behind our change in our guidelines. There are actually 5 now, but there's 4 blood pressure trials that actually address blood pressure management for intracerebral hemorrhage. And I'm very proud to say that we were part of the ATAC-2 trial. So the ATAC-2 trial talked about really aggressive blood pressure management, which is 110 over 139 versus 140 to 179. And they trended them to see how they did. And from there, they found that there was actually no difference. However, based on a meta-analysis, they showed that you had worsening outcome for renally impaired patients. And as you know that a lot of our patients have concurrent kidney impairment when they come in with their strokes. We have a high incidence of kidney impairment. So it was like clockwork. Whenever we randomized the patient and they were sent to the ICU, usually they got worse if they were in the aggressive arm. And we actually noted that in the steering committee for ATAC-2. And because of that, we actually help them influence and tell them to make sure that they wrote that in their paper. And ultimately, it helped us put this in our guidelines, which is it's harmful. Please do not lower the blood pressure less than 130. It's very important that you don't lower the blood pressure less than 130. So that's really important. You can actually hurt the patient even further. So we do know that in the 2020 International Society guidelines, it talks about that the blood pressure should be at 130, but not less than 130 for intracerebral hemorrhages, and that the primary agent should be labetalol and nicotine, not hydralazine, not nitrate, not not enalaprate. What else do we use? I don't know what else you guys use, but all I know is these 2 blood pressure ones. So those are the only 2 in my vocabulary. And so it's important to realize that you have this type of blood pressure and that you continue to drop the blood pressure, but not to be less than 130. This is actually straight from the Interact-1 trial, and I always thought this is quite delightful. It tells you the sequela, the natural sequela of intracerebral hemorrhage. The natural sequela is that during the first 6 hours, 50% of the hematomas will expand, right? So it's 35 plus 15 here, it's 50%. So it really tells you that in the first 6 hours, if they're going to expand, 50% of them will expand. And because of that, we sometimes say, let's do a CAT scan in 6 hours instead of 24 hours. But 24 hours will then truly encompass all 100% of all the cases. And as you know that they demarcated how the blood pressure, how high the blood pressure was when they did hematoma expansion. And the cutoff seems to be at 160. So try to keep that blood pressure less than 160, but not less than 130. So it's really hard to keep that in mind, but I know you guys can do it. So can we do this? And can we actually reach our goal within 1 hour? I think so. I think that we are we survived COVID. We are a level 1 trauma center. We just talked about traumatic brain injury. Of course, we can handle blood pressure and hit it to the goal within 1 hour. Absolutely. I think that we should, yes, ideally drop that blood pressure to 130. So if a patient is newly diagnosed with intracerebral hemorrhage, try to give a drip as soon as possible and then lower that blood pressure to 140. Yeah. I went a little crazy with the animation. Like once I did it, I couldn't stop. So I'm sorry. So, but just remember that this blood pressure is harmful if you drop it 130. How many of you guys rotate at Kings County? Okay, I think all of you guys are required. So how many times have you say, well, I would like the blood pressure to be 140, but it ends up being 130? All the time. Yes. So that's what I give everyone a margin of error. So that's why I did 140 to 160, because usually if I say 140 to 160, the blood pressure is usually 130. If I say 130, the blood pressure is going to be 100. So usually I tell the nurses to give them a margin of error to 140 to 160. And remember, this is the last time I'm going to say, do not drop the blood pressure less than 130. It is harmful for these patients. So let's talk about radiographic predictors. So, you know, when you guys go and rotate in stroke, hopefully you guys go to our stroke codes. And when you do see a hemorrhage, there's some radiographic features that you will see that will say that these are going to be expanders. These are going to be hematoma expanders. And one of them, you know, there's actually 3 signs, but there are 3 signs, but the most obvious signs are the spot sign, which is a contrast extravasation that occurs in CTA. So contrast extravasation is usually a dot here. You do a CTA after the CAT scan and it shows that it's ongoing intracranial hemorrhage. This is a prognostic sign that the patient most likely will have hematoma expansion. And it will often, you know, a lot of people will opt to say, you know what, I'm going to repeat the CAT scan 6 hours instead of 24 hours because 6 hours is sooner than 24 or even sooner. There's also something called the swirl sign, which is a heterogeneous morphology. It looks like a side loading. Does anyone here do laundry anymore? I'm pretty sure people do laundry. It's a side loaded washer, and you see the whirly pattern on the intracerebral hemorrhage. And why do we do CTAs? Well, CTAs now have been changed on a more diagnostic picture. It's just like stroke codes now for ischemic strokes. We should do CTAs on a more normal basis. And this is based on the diagram registry, which says that if a patient comes in with evidence of intracerebral hemorrhage, but you can't call for the etiology of the hemorrhage, you should think about doing a CTA. And if it's a young woman, you should consider doing a venous runoff. So this is based on the diagram registry. Now, you don't need to do it immediately. You have 24 hours to do it. But since the patient's already in the CAT scan for an acute stroke, you should consider doing it in the first 24 hours immediately. And so I gave 3 case scenarios of when you should do vascular imaging on these intracerebral hemorrhage patients. If it's a patient less than 70 with a lobar hemorrhage, you should think about doing a CTA. That means it's on the side, you're ruling out an AVM. If it's a patient who's less than 70 with no evidence of hypertension and it's a posterior fossa intracerebral hemorrhage, you should consider doing a CTA. We already do this, but now it's being codified. And if it's definitely a very young patient, you should do a CTA with a venous valve. And so those are the main reasons why you should do it. Majority of our cases are actually hypertensive bleeds, but we do see some patients that may benefit from vascular imaging. Again, Dr. Hassel's slide, just to tell everyone. So we do know that for imaging, bleeds come in a spectrum. So obviously this patient, Dr. Feinberg says, okay, this patient's going to stay in my ICU for less than 24 hours and off you go to stroke plan for aggressive discharge, right? Yes. For this one, may stay a little bit longer. I don't know, maybe for a day or 2. This patient will probably, and obviously it's a catastrophic bleed. And she says, oh darn, this patient most likely will not do well. And it always makes us upset when a patient doesn't do well because it is not our intention that the patient doesn't, you know, it's not our intention. The patient did not say, I'm going to wake up today and have a massive hemorrhage. No, they want to live their life. And obviously this patient will be devastated and disabled. I'm going to talk about this because we don't talk about it enough. So I just want to bring it up. There's something called T wave, cerebral T wave. You commonly see it with intracerebral hemorrhage. It's associated with high increased intracranial pressure. And this is like straight from like edstatpearl.org, but I thought it was really nice to say here, they're intracerebral T waves here. And usually when you see them in majority of your precordial leads, you suspect that this patient is not only having a catastrophic bleed, but you should also think about other etiologies that can cause cardiac dysfunction. Okay, so can anyone tell me what this is? I will never bother you for another stroke code again if one of the residents name this. Someone scream it. Oh, okay, I will never bother you now for a stroke code ever again. You just want to pass for the entire. So yeah, it's apical ballooning. And this is not our imaging, but we actually have a patient upstairs who has Takotsubo right now. And the Takotsubo is neurogenic cardiac sudden myocardium. There is a Mayo Clinic diagnosis criteria. It actually expanded. We typically, this is textbook case, but now they actually expanded the criteria for using the Mayo Clinic diagnosis, criteria. Which basically asks for is that there's an absence of significant coronary artery disease. And the patient that's in our neuro ICU right now has a basilar artery occlusion and had a catastrophic stroke. It was seen that there was some, T-wave inversions in the precordial lead. And we asked our very, very, very wonderful Dr. Rashid to do a bedside echo. He said, yeah, you're right. This patient may have Takotsubo. And usually we ask them to avoid beta blockers. We're always afraid of worsening their cardiac output, but it might be a myth, but we're still very religious, like let's not give beta blockers to these patients. So as far as blood pressure management, try to keep it lead between 140 to 160, but not less, and don't push it less than 130. But these are all of our stroke, ischemic stroke, blood pressure goals. I need to give a shout out to Dr. Beta. I have to tell you, I constantly bother Dr. Beta. It's really bad. Like, it's just incessant. It's really bad. You should look at him and feel sorry for him about how many times I bother him. And I call him constantly. Why? Because he takes care of the most complex stroke patients when they come from the ED. He takes care of the TPA patients. He takes care of the hemorrhage patients. So when you look at him, you say, I feel so sorry for him. So we worked on a project together, as well as Dr. Feinberg, on improving our neuro checks as they wait, for intracerebral hemorrhage patients, as they wait to go to the neuro ICU. And as you can see here, this is our pathway. A lot of our patients will get CTA, but in the end, they're waiting for the neuro ICU. All bleeds go to neuro ICU. There are some exceptions, like the really tiny bleeds, and that will be a discussion between stroke and neuro ICU, but almost all intracerebral hemorrhages go directly to the ICU. Did you guys know that we have order sets? Okay, I see a nod here. But yes, we have order sets here. We have order sets. It's called BD post-imaging hemorrhagic. That means that after your imaging, if there's a bleed, you should click on this order set. This order set will help you do neuro checks and everything. Just want to let you guys know that. But when it comes to intracerebral hemorrhage, you always want to keep that the vital signs is 215 if the patient's on nicardine drip, and otherwise 2-1 hour. If there's a subarachnoid hemorrhage, you want to keep the blood pressure very similar to intracerebral hemorrhage, but maintain that the neuro checks are adequate. Now, as you can see here in the orange, this is Dr. Feinberg's unit. Look how glorious this orange is. It's so high, even 100%. ED is blue. I will not comment on blue, but there is definitely room for improvement. But it's okay. Do you want to know why? Because now you know, and Dr. Beta knows, everyone knows. I tell Dr. Beta all the time that we have lots of room for improvement. He says always room for improvement. And I love that. So we always want to make sure. Yeah, I know. I saw that. Look at this. You see this? Yeah. Yeah. So, but the thing, it all starts with you as the medical team. If the medical team puts in the order and then engages nursing, it's always great. Dr. Feinberg, orange. Yeah. Yeah, so for bleed. Yeah. 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 And yeah. But also we do want to let you know that whenever TPA or bleed day, it's an arm day for us, for stroke team. So we're like Domino's pizza. We will send the patient out. So we will deliver. So as the role for surgery, and this is what becomes challenging for role of surgery. We still have time. For this cerebellum, now it's no longer 3 centimeters in diameter. It's usually a volume, 15 ml. It's about the same, but 3 centimeters versus 15 now. And that for the EVD, when do we do EVD? Everyone gets an EVD. Dr. Feinberg is the Oprah of EVD. Everyone gets the EVD. So you get an EVD, you get an EVD, you're cool and you're getting an EVD. She is the Oprah of EVD. Everyone is getting an EVD now. Anyone with hydrocephalus contributing to decreased consciousness, you're getting an EVD. Why is that important? Because that now expands what the goal of surgery is for the patient. You're okay that I called you Oprah of EVD. So how do we predict? Using the ICH score is not the sole predictor of patients' morbidity mortality. Obviously, it's a case by case, but it gives you a general idea of where the patient is going to go. As you can see here, when you calculate the ICH score, the cusp is actually between 2 and 3. It actually triples in your 30-day mortality rate. But I will say this, ever since Dr. Feinberg started, I've noticed that when we get downgrades, usually we get downgrades around 3. ICH score of 3. But ever since she started and our ICU started to send us more, we've been seeing ICH downgrades of 4 and 5, and they still survive. So we noticed that they shift of survival rates in the ICU. No, it's very bad. They are modified Rankin 5. They are 5. 5.5, 5.5. Not quite 6, but 5.5. But the thing is that it really depends on the family, on well, we could talk about this, we could talk about disparities and inequities, but we do know that, and you bring up a very good point, is that minority population is less likely to go to palliative route for intracerebral hemorrhages rather than Caucasian patient population. They're less likely to do palliative route. And we do cater 95% of our stroke patients are African American or Afro-Caribbean, and it's something that we need to work on. I hate to say it, we need more aggressive palliative care, but so what can you do as ED doctor when they first come in the first hour? Make sure the labs are done, make sure the CAT scan is sent, and if you do have to reverse them, please reverse them. We do know that no one uses Coumadin anymore, but I have to talk about it, is that you give PCC over FFP in addition to vitamin K. As far as DOAC-induced intracerebral hemorrhages, you should give a Dexamine. I am currently fighting with central office on the Dexamine. It's okay. I will fight them. I'm very persistent, so we'll figure this out. So this is the table that you should know when it comes to reversal. If someone is on apixaban and they are within 2 hours up to 8 hours, they should receive charcoal. That is class 2B evidence. But and then if they have if you have a Dexanet, it's a class 2A. But if you do not have a Dexanet, do you have a Dexanet here at Downstate? No, right? Okay. So then you give 4-factor PCC. And the reason why 4-factor PCC is better is because it contains 25 times higher than FSP and vitamin K dependent. And there was actually a trial that really evaluated. This is based on the INCH trial where the FSP versus PCC, and they found that PCC was better and it was quicker. Remember, give PCC. When in doubt, give PCC. And that don't need to talk about it. But you should know that reversal and knowledge of reversal of DOAC is a Joint Commission requirement of every hospital. It is a requirement. So anywhere you go, even outside of downstate and Queens County, whenever you go to hospital, hopefully you will be at a hospital that is Joint Commission certified. But when you go to a hospital, just make sure that you must follow this practice of reversal and knowledge of reversal. As far as someone who's on antiplatelet therapy, we recommend BD-AVP, but no platelet infusion, and this is from the PATCH trial. The patient should only get platelet if they're getting some sort of EVD from EVD OPA. Yeah. Okay. As far as seizures, just make sure that seizure prophylaxis is not recommended on these patients. It actually shows no benefit to provide it. Only if they come in with seizures, you should give them seizure prophylaxis. And as far as rehab, you should postpone for 24 hours. Okay, so how are we on time? We have no time. No time? That means I'm done? I'm really done? I'm really done? Okay, I'm just gonna quickly talk about intracranial hemorrhage. So I'm just gonna briefly just talk, okay, so so you just have to know if someone is bleeding from TPA, stop TPA, okay? I think I have to, this is a hassle slide. Stop TPA, give 10 units of cryo. Repeat the fibrinogen to make sure the fibrinogen is greater than 150. That's your goal, right? And then repeat the CAT scan in 6 hours. This is a hassle slide. And then in order to prevent that, you just bring the patient upstairs. Just, you don't want I know you don't want the patient in the ED. Just send the patient upstairs. And we're more than happy to accept the patient. And that we frequently check on the patient throughout the night. I do want to let you know that our TPA administration rate is quite good. You know, actually, national average is around 25% TPA. We're actually around 11%. But our hemorrhage rate is 0. We only have 1 TPA bleed. She's still in the ICU. We have 1 TPA bleed for 2023. We usually have 1 TPA bleed a year. So we're done for 2023. Just want to let you know. And that our aggregate is 2.5% bleed. I always tell this, and Dr. Sanders always listening. I always want to give you our TPA related bleeds because it's important to know. Any hospital that you end up going to, you should always ask, what is your TPA related hemorrhage rate? I do want to brush up on a trial called the CERTAIN trial, and it talked about symptomatic intracerebral hemorrhage associated with connected plates versus alteplase. And that this trial just got published in JAMA, and it actually told you that the overall TPA hemorrhage rate is less than now 4%. It's actually 3.6%. So you should, so keep that in mind when you go out to your hospital, or if you end up going, you ask what's your TPA related bleed, it should be less than 4%. Now, connect place is actually 1.8%, and that is really strongly pushing me towards using connected place in the emergency room at Kings County. It's coming to Kings County soon. All right, and I do want to give a shout out to our neuro ICU colleagues as well as the ED. We're doing a good job in the sense that we are taking very good care of our patients. I don't know if you noticed here, this is a time where a lot of patients do not do very well. There's a very high mortality rate. Ever since the introduction of neuro ICU has really dramatically decreased our overall stroke mortality rate, or intracerebral hemorrhage rate, and our subarachnoid hemorrhage rate. And this is in comparison with national average. So we do monitor this, and you are doing a very good job. And there's always room for improvement, of course, but I just want to let you know you're doing a great job, and thank you for your dedication taking care of all the stroke patients. All the stroke patients come from you, by the way. They don't just walk in and say, yeah, I need to go to the 6th floor. They come from you. So I just say thank you.